Mr. Garrity is a 52-year-old male, appearing thin, disheveled, and doesn't appear to attend to his hygiene needs. Mr. Garrity is confused, his affect is blunted and sometimes inappropriately labile. Mr. Garrity is an inpatient at a mental health care facility as he was presenting as a danger to himself. Mr. Garrity was wandering the streets, talking to himself and confused. Mr. Garrity was diagnosed with schizophrenia when he was 18 years old. Diagnostic criteria Part A. Schizophrenia in adults has at least one of the following symptoms present for a significant portion of the time during a 1-month period: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, or negative symptoms. Diagnostic criteria Part B. For a significant portion of the time since the onset of symptoms, since the onset of disturbances in individuals' level of functioning in one or more areas such as work, interpersonal relations, and self-care is below the level achieved prior to onset. Diagnostic criteria Part C. Signs persist continuously for at least 6 months. Within this 6-month period, at least one symptom found in criteria A must be present. Periods of prodromal or residuals may occur. During these prodromal periods, the signs of disturbances may be manifested by only negative symptoms or by 2 symptoms listed in criteria A presenting in lesser severity. Diagnostic criteria Part D. Schizoaffective disorder and depressive bipolar disorder with psychotic features have been ruled out because 1. No major depressive or manic episodes have occurred concurrently with the active phase symptoms. 2. If mood episodes have occurred during active phase symptoms, they have been present for a minority of the total duration of the active and residual periods of the illness. Diagnostic criteria Part E and F. E. The disturbance is not attributable to the effect of another medical condition or substance, such as drugs, medication, or alcohol. F. If there is a history of autism spectrum disorder or communication disorder of childhood onset, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations, in addition to the other required symptoms of schizophrenia, are present for at least 1 month. The evidence for the direct dependence of intact cognitive function upon the integrity of the prefrontal cortex in schizophrenia is overwhelming and takes several forms. A persuasive line of support comes from a PET scan of deficient blood flow or metabolism in the prefrontal cortex of schizophrenia subjects, particularly during behavioral performance. An equally strong line of evidence derives from neurophysiological and neurophysiological observations that have repeatedly highlighted similarities of impairments observed in patients with schizophrenia and in those with frontal lobe damage. Patients compromised by frontal lobe lesions in schizophrenia patients are similarly impaired on the continuous performance tasks and on tests of categorization and flexibility. In the case of Mr. Garrity, the nurse's role is to focus on client-centered care, interventions when needed, and providing appropriate resources for when Mr. Garrity is discharged. Close and frequent monitoring of Mr. Garrity is important as he is experiencing frequent hallucinations. Mr. Garrity can be seen moving his lips while alone, as if he were hearing and talking to someone, and this is a characteristic of a hallucination. Small and frequent interactions with Mr. Garrity would be the best, as he cannot focus for long intervals. Short 15-minute intervals appear to work best, and during these times, Mr. Garrity talks with the nurse for short periods. Him and the RN have been able to participate in small, simple group activities, especially those that involve refreshments. Another thing is ensuring safety. Mr. Garrity is experiencing illusions. He is convinced that the shadows he sees on the walls are trying to harm him. Reassuring and redirecting Mr. Garrity is important. Non-pharmacological treatment. First one is Program of Assertive Community Treatment. It's designed for most poorly functioning patients. Its purpose is to prevent relapse, maximize social and vocational functioning, and keep individuals in the community. Its purpose is to emphasize patients' strengths so they can adapt to the community, providing support and assertive outreach, involving almost all aspects of the patient's life. Family therapy. Family participation in treatment is emphasized and has been proven to a better patient outcome. Family members of an individual with schizophrenia often experience hardships, oftentimes causing the individual to become isolated. The psychoeducational approach brings educational and behavioral approaches into family treatment. In family sessions, fears, faulty communication patterns, and distortions are identified, With this, problem-solving skills can be taught. Cognitive behavioral therapy, or CBT, is used in conjunction with medication to reduce frequency and intensity of delusions and hallucinations. CBT promotes treatment resistance, improves insight, compliance, and alleviates aggression in patients. Social skills training, or SST, can improve the level of social activity, foster new social contacts, improve quality of life, and help lower anxiety. And the recovery model adapted for schizophrenia. According to this model, recovery has many different pathways. Each person is unique, so treatment needs to be personalized and holistic. The recovery model focuses more on hope, rebuilding self-image, and coping with life challenges, rather than focusing on the individual's symptoms. The nurse needs to assess for patient readiness and treatment participation. A holistic, patient-centered approach is ideal, therefore patient participation is essential. Assess for auditory or visual hallucinations, pay specific attention to command hallucinations. Assess the patient's belief system, as this can have a direct impact on the course of treatment and how well a patient will respond to treatment. Assess for the use of alcohol or other drugs. Assess for depression, suicidal ideation, homicidal ideation, anxiety, or a history of violence. Assess the patient's support system, and along with this, assess the interactions between family and patient. Is it positive? Does the family understand the disease and the need for treatment adherence? How does the family respond to an increase in positive symptoms? And ensure patient is meeting basic needs. Are they dressed appropriately? Are they well groomed? Is hydration and nutrition adequate? Pharmacological treatment. The recovery model for schizophrenia is often incorporated in pharmacological treatment in patients with schizophrenia. Antipsychotics are the drug of choice, and though they may alleviate some symptoms, they don't cure the underlying psychotic process. When a patient with schizophrenia stops taking their medication, psychotic symptoms return. One concern in particular is each time the medication is stopped, it takes longer for remission to begin after restarting the medication. When stopping and restarting the medication happens frequently enough, the patient may eventually become unresponsive to treatment. First-generation antipsychotics. These drugs have been known to cause troubling side effects. However, first-generation antipsychotics are now being used more commonly due to their cost-effectiveness. Though there can be serious side effects when taking first-generation antipsychotics, they are generally safe when taken regularly. First-generation antipsychotics work by blocking a variety of receptors within and outside of the central nervous system, including dopamine, acetylcholine, histamine, and norepinephrine. In psychosis, dopamine receptors are blocked in the mesenteric region of the brain, but they also affect D2 receptor sites in the limbic and motor centers. The blockage in the D2 receptor sites are responsible for troubling side effects. Mr. Garrity was getting biweekly injections of fluphenazine, though stopped going to the community clinic to get his injections due to the extrapyramidal side effects he was experiencing. Nursing considerations for first-generation antipsychotics. First off is adherence. Adherence to antipsychotics is the most essential. As I said, when an individual continuously stops and starts a medication, it can become resistant to treatment. Over the course of several therapeutic interactions, Mr. Garrity revealed that he stopped taking his medication injection because of the way it made him feel. He described symptoms of tremor, slow speech, uncontrollable restlessness, muscle spasms of the neck, and grimacing. These extrapyramidal symptoms are troubling to clients, and some symptoms can be controlled, most are reversible, but almost all antipsychotic drugs have some potential for causing these side effects. So that is one special consideration for the nurse, is the extrapyramidal symptoms. They are also commonly referred to as the troubling side effects. One in particular is tardive dyskinesia. This typically appears after prolonged treatment. It's serious and not always reversible. Tardive dyskinesia consists of involuntary tonic muscular spasms that will typically involve the tongue, finger, toes, neck, trunk, or pelvis. This is most commonly seen in women or older patients. Catching this early is key in prevention. Early signs can be identified as constant smacking of the lips or tongue. Neuroleptic malignant syndrome occurs in about 0.2 to 1% of patients taking antipsychotics. It is believed the acute reduction of dopamine activity may play a role in the development of neuroleptic malignant syndrome. Neuroleptic malignant syndrome is characterized by a decreased level of consciousness, increased muscle tone, hyperpyrexia, labile hypertension, tachycardia, tachypnea, diaphoresis, and drooling. Agranulocytosis, severe and dangerous lowered white blood cell count, occurs when the bone marrow doesn't produce enough mature white blood cells, so exposures to infections can be deadly. And then also possible brain damage. More recently, there has been concern that antipsychotics contribute to brain damage in people with schizophrenia, and it may be associated with the severity of cognitive symptoms seen in patients with schizophrenia. Dosage, duration, and specific drugs are considered all to be factors. Pharmacological treatment. Second-generation antipsychotics, or atypical agents, are often the first treatment choice. Olanzapine, an atypical antipsychotic, is effective in treating both positive and negative symptoms of schizophrenia, with very few unpleasant side effects. Mr. Garrity is now taking it by mouth once a day. With compliance to treatment, olanzapine may help Mr. Garrity's symptoms within a few days to a few weeks. Nursing consideration for second-generation antipsychotics. Specific to olanzapine, appetite increases and weight gain may occur, so weight should be monitored and healthy eating and exercise should be taught and encouraged to avoid or manage weight gain. Mr. Garrity can be taught to drink water before meals to help him feel full and hopefully eat less. Drinking a lot of fluid will help avoid constipation, which also can occur as a side effect. High-fiber foods and raw fruits and vegetables will also help in controlling weight and avoiding constipation. Postural hypotension is a possible side effect of olanzapine. Mr. Garrity should be told to rise slowly from a sitting or lying position to avoid dizziness. In addition, Mr. Garrity should also be aware that olanzapine may cause him to feel drowsy. So as I said, weight gain is the most common side effect of a second-generation antipsychotic. It's important to monitor your patient for weight gain and what their diet is and how to prevent weight gain, especially in these patients, as this is a common reason why people cease treatment. There is an increased risk for diabetes, there is a glucose dysregulation, and the increase in gait weight, so make sure you monitor your patient's A1C and again the diet and exercise. Hypertension, monitor your patient's blood pressure with each visit and advise them to check their blood pressure periodically, maybe even if they go to Walmart for their groceries or Hannaford, they have those blood pressure cuffs that you can check outside of the pharmacy if they are able. And then a decreased self-esteem that is directly related to the weight gain. Potential risks and complications. Mr. Garrity has a notable decrease in self-esteem. Assess Mr. Garrity for suicidal ideation, low self-esteem, difficulty in seeking help, and difficulty in living with such a chronic and all-encompassing illness and auditory hallucinations that command suicide are contributing factors to suicide. Though it was determined that Mr. Garrity is not suicidal, we need to assess him every time. It is important for Mr. Garrity to stay in communication with his social worker as well as other healthcare professionals when he becomes concerned about his treatment plan, especially when he's considering ceasing medication treatment. And then hallucinations. The content of Mr. Garrity's hallucinations may include self-derogatory themes or even command to self-harm. It is impossible to assess the content of hallucinations and determine if they include command or self-harm or if they are derogatory. It's always important to ask Mr. Garrity about the meaning of his hallucinations to him. The prognosis and conclusion. Mr. Garrity's prognosis is positive looking forward if he remains compliant with treatment and utilizes community resources. Mr. Garrity has been experiencing fewer episodes of hallucinations, and clearer verbal communication suggests that Mr. Garrity's anxiety has lessened and that the olanzapine that he's been taking every day regularly is effective. Mr. Garrity has begun to attend various therapy sessions. It is important that he continue to attend consistently so that he can realize success, a sense of accomplishment, and enhanced self-esteem. It would be realistic to expect the attendance at the sessions could be consistent and continuous. Mr. Garrity has assumed some responsibility for his own basic activities of daily living, though independence with ADLs probably is unrealistic for Mr. Garrity, but an increased independence is reasonable. As Mr. Garrity's anxiety eases, he discusses the transition to the halfway house. In the past, he has become overwhelmed trying to take care of himself after discharge, so he appreciates the bed, food, and compassion he feels when the staff is there. He likes having a nurse nearby if he has trouble with his medication. In his life skills class, Mr. Garrity has been learning shopping and cooking skills. He has also learned about preparing menus that include healthy foods that can help him avoid weight gain. Mr. Garrity has also been learning about his medication, the expected side effects, and what to do if they occur. After 2 months of treatment, Mr. Garrity's condition has dramatically improved. He spends his daytime hours in the community halfway house program and his nighttime hours on the hospital unit. He meets with a nurse twice a week on the unit. Mr. Garrity is scheduled to begin a part-time job at a church near the halfway house. He will also begin participation in the psychosocial clubhouse program in his community.